Well, welcome to today's talk. Thank you for coming back. It is Wednesday, the 17th of February, 2021. Now, I want to review a few different data sets and ideas from around the world today. This is going to include a review of information from the Office for National Statistics in the United Kingdom, because I've been absolutely appalled by the level of excess deaths in people with disabilities, especially people with learning disabilities. So physical disabilities, yes, but learning disabilities particularly badly affected. And this really is a problem and somewhat of an indictment, it has to be said. I'm going to start off briefly with the United States today. Now, we've looked at this graphic before. This is the latest version. I've just downloaded this now. So Canada cases going down, and this twin fall in cases, once adjusted per capita, again really quite uncanny, between the UK and the United States. Now, in the United Kingdom, we're not as locked down as we were in the first lockdown, back in the first wave. I mean, we say we are, but in actual fact we're not. But the cases are coming down due to pretty restrictive measures, it has to be said. So that's really why the cases are coming down in the UK. Now, what I'd like to do now is explain in detail exactly why the cases are going down as they are in the United States. I want to explain this drop-off, most welcome drop-off, in exact detail and precisely. But of course, unfortunately, I can't. I don't think anyone in the world can. I mean, why are the cases coming down as nicely in the States? Now, we're not saying we're out of it yet. There's no space for complacency here. So there's a change in behaviour in the States, yes. On an individual family basis, yes. There's more mask wearing. But last weekend, people were flying around quite a lot. There's still a lot of internal movement going on. The restrictions on international flights, which is good. But it really is quite hard to explain the fall in cases that we're seeing in the States. I just think it's the summation of millions and millions of individual behaviours that people are becoming accustomed to this idea of the pandemic and the need for restrictions. Is vaccine starting to have an effect? Probably not too much yet. Although it's going reasonably well, although difficult at the moment with the storms, of course. So herd immunity, is that a factor? Well, it probably is starting to work to some extent, but really we don't know. But it's very welcome. So very welcome, but no space for complacency yet. Now, going on to the States, storms are causing disruption. I mean, amazing. Wind turbines iced up in Texas. I don't know if that's common, but I always associate Texas with being warm, but not at the moment. And of course, this has interfered with vaccination programs and schedules. There are logistical and supply issues in the United States. And I am a bit surprised by that. I would have thought the United States would have had better internal logistics than they have. So scope for improvement there for sure. Huge federal vaccine centres opening, and I know at least of one opening. I think several are opening now. This is going to accelerate the rollout over the next few weeks, no question about that. So 56 million doses of vaccine given essentially. Second dose over 15 million, still only 4.65% of the population. But we add that to the percent of the population which has herd immunity, and they are additive effects. But of course, we have to wait, don't forget, when someone's vaccinated, there's 3 weeks before there's any immunological benefit. Hospitalizations still stretched in many areas, but overall down. So encouraging. Past 7 days in the States, looking good. Now, we are going down from a high level, from a high plateau. That's a high peak, that's for sure. I mean, cases were, dangerously dangerous. Well, they were, still are dangerously high, but they were terrible just before. And so that is starting to come down, which is good. New daily reported cases down 23.7% in the past 7 days. Deaths still very high in the States. Now, it's not going to be long now before the deaths in the States reach 500,000. That is completely inevitable because of the baked-in cases that we have. Quite inevitable, and it will go beyond 500,000, unfortunately. But the rate is starting to come down. It's still high, but it is starting to come down week on week. COVID-related hospitalizations down 18.4%. Test positivity rate way down, 5.5%. Now, this is still high. It's still above the epidemic threshold. But so much better than we have seen. So it's encouraging. No scope for complacency at all, because there is still the very real possibility of a significant bounce back as a result of new variants spreading in the States. We are not there yet. But so far so good, and to tell you the truth, it's kind of a breath-holding situation, isn't it? What's going to win, the variants or the vaccines? Because I think that's probably what it's coming down to at the moment. And let's hope the vaccines beat the variants, but they are still a very real risk. Now, moving on to the Office for National Statistics in the UK. I'm going to start off with the Antibody Survey first, which is interesting. People that have obviously been exposed to COVID-19 develop the antibodies. These are the immunoglobulins that help us fight the disease. This is the 28 days up to the 1st of February. So this is basically data for January. Now, England, 18.5% of the population had antibodies. Now, that basically means they either had the infection, basically they had the infection for about a week to develop an antibody response, or they'd had the infection in the past 3 months. So it's getting on for a fifth of the population, isn't it, in England, has had the infection in October, November, December, January. Now, what's the total number that have had the infection, of course? Because of the fading in antibodies, is it double that? Probably not quite, but I think it means it's certainly well into the 30%, 35% or so of the population of England have had COVID-19 since this pandemic started. Over a third of the population. Of course, that means a lot of people can still get it. We're not there yet. But interesting to note how many people have had this infection. It's probably a third of the population in England have had it. So that number, 18.5%, equates to 18.3 million people, and that's just over the age of 16. Now, in 80-year-olds, even up until the 1st of February, more over 80s testing positive for antibodies. And of course, the reason for this is because that is the group that were vaccinated first. So this is really good news on the effectiveness of the vaccine in terms of generating antibodies. Doesn't tell us how many people are not getting the disease, how much less the disease is being spread, how many less people are dying. We believe that's true for other reasons, but it does tell us that the vaccines are working to produce antibodies. And of course, if they've produced antibodies, they'll have affected other parts of the immune system, like the memory T cells, the B cells, the natural killer cells, and various other immune cells that will have been stimulated by this vaccine. The antibodies being just one part of the immune response. It just happens it's the easiest to detect. So that's good. Wales, the overall prevalence was this is the overall prevalence for antibodies up till the 1st of February, 14.4%. Northern Ireland, 13.6%. Scotland, slightly less at 11.7%. So a lot of people have been exposed to this disease already. Now, moving on from antibodies to actual cases, always the frustrating delay, of course. This is the week ending to the 6th of February, just published by the Office for National Statistics. England, the prevalence was down to 1 in 80, but that is still 695,400 people. That is still a lot of people with the infection in the first week of February. That's the prevalence figure. Week ending the 30th of January, it had been much higher, so we see it's gone down from 846,000, nearly 847,000, down to 695,000. So a nice reduction, but still a high number. So 1 in 80 in England, 1 in 85 in Wales, 1 in 75 in Northern Ireland, 1 in 150 in Scotland. And now we're going to look at deaths now, and this is where it does become pretty disturbing, really. I'll give you a bit of background in a minute, but so deaths week ending the 5th of February, an extra 7,320 deaths in the week from Office for National Statistics data. Now that's down compared with the previous week. So it's down over 1,000 deaths. But of course, you can still see that's still over 1,000 a day, whereas the week before it had been well over 8,000. So yes, the trend is good. Yes, the numbers are still high. In this week, up to the week ending the 5th of February, first week in February, just the end of January, COVID-19 still accounted for 42.6% of all deaths in England and Wales. And the numbers wouldn't be too dissimilar in Northern Ireland and Scotland. So this is the major cause of death at the moment in the UK by far and away. Now, disabled people, they collected data from the 24th of January to the 20th of November 2020. So quite longitudinal study. And disabled people are at increased risk of death. Now, how disabled someone is a little difficult to quantify. What they actually did was they took the data from the 2011 census, which was the last full data available, and people classified themselves as slightly disabled, more severely disabled. It was their own classification. But this is what they found. Men who are not disabled, well, we'll take those as 1. We'll take that as, that's the reference point. People that were slightly disabled, it was times 1.9. People that were more disabled, 3.1. So 3 times more people dying with greater levels of disability compared to people without disabilities. This is triple the death rate. And that is certainly pause for thought. So my mind just went there to friends I've got who are, long-term patients and friends who are disabled. This is real people we're talking about here. Remarkably increased death rate. Women not disabled as the benchmark. Slightly disabled times 2, 3.5 times more likely to die with greater levels of disability. This is they're really quite startling statistics, actually. But it's from the Office for National Statistics. Now, the learning disability one, I had to look at the graph a few times to make sure I'd got it right. They're 3.5 times more likely to die after adjusting for age. Age-adjusted risk, 3.5 times with learning disabilities. And of course, many people with learning disabilities do not have physical disabilities. Some do, many don't. And the reason this kind of got to me is I have come across attitudes to people with learning disabilities throughout my long career that aren't what you'd like them to be quite honest, amongst healthcare professionals. Not saying it's the same now. My career goes back 40 years, I'm afraid. But I have come across attitudes which almost expect morbidity and mortality with people with learning disabilities. This has to change, and this is live data as of 2020, 3.5 times more likely to die from COVID. So this is no two ways about it. These figures for disabled people and learning disabilities people are an indictment on our society. They really are, and they need addressed pretty urgently, really. But that's the figures for last year. People have always been saying, 10 years ago we had a problem, now it's okay. But people were saying that 10 years ago and 10 years ago and 10 years ago. And things are still bad in 2020. That is an indictment. Now, Zimbabwe. This is interesting. Now, Zimbabwe, of course, has suffered under, shall we say, suboptimal government. Government which has not always been completely transparent, has not always been completely honest even, potentially. And they're suffering the consequences of that now. And China has somewhat stepped in. 200,000 doses of vaccine donated by China have now arrived in Zimbabwe, and they're going to start vaccinating healthcare professionals soon. 600,000 doses arriving next month from China. So the Chinese vaccines are arriving first in Zimbabwe and indeed other countries, which is interesting. Now they're expecting vaccines from Russia as well, India and the United Kingdom are on their way, but not there yet. There's no two ways about it. The Chinese have got there first. And I'm pleased because the people in Zimbabwe, starting with the healthcare providers, are going to start getting vaccinated. Now, the vaccine is Sinopharm. That's their vaccine. Check it out. This is just the basic information from the New York Times tracker, which is very good. Now, the original efficacy was 79.34%, which is good. 2 doses, 3 weeks apart. So this looks like an efficacious vaccine. Now, it's from the Beijing Institute of Biological Products, and it's an inactivated coronavirus vaccine. Now, this is the old-fashioned way to make vaccines. Basically, what they've done is they've brewed up lots of this virus, presumably in cell cultures, and then they've killed the virus and put it into the vaccine. And that means that basically, as I understand this vaccine, all of the dead virus is being injected into the individuals. And because the dead virus contains the antigens, these particular antigenic molecules that the immune system will recognise as being foreign, an immune system is mounted to this foreign protein. Then when the live virus comes, it's attacked in exactly the same way. Old-fashioned way of making vaccines. And I must say, it's not just targeting particular spike proteins, it's proteins from all parts of the virus. So this is going to have a very wide-ranging immunological response as the body responds to different protein types in the virus. So I'm not surprised that this is an efficacious vaccine. It's looking good so far. Now, it's been approved in China, although it's not been widely rolled out in China. They are planning to vaccinate a lot more people pretty soon in China, but it's not really happening quite yet. United Arab Emirates and Hungary have approved it. China have given 1 million doses so far. There are no phase 3 publications on this vaccine. Yet, we must assume that the data for the Chinese, the UAE and the Hungarian authorities to make some sort of informed decision is there, even though it's not in the public domain. Ongoing phase 3 trials in the United Arab Emirates, Morocco and Peru at the moment. So we are expecting a publication at some point, but it's not there yet. United Arab Emirates gave it initial provisional approval, now given it full approval, and they're saying the efficacy is even higher at 86%, according to United Arab Emirates data. So we would want peer-reviewed publications. We haven't got them, but this is several countries now reporting good results, so it sounds good. Chinese researchers tested it against variant B1351, South Africa variant, and they said the antibody response is only modestly weaker. In other words, it's having a good antibody response against this new South Africa variant. Now, again, this isn't too surprising really, because as we've said, if you're injecting the whole dead virus, many parts of the immune system respond to many different proteins in the virus. So the fact that you've got 3 or 4 specific mutations on the receptor binding domain in the spike protein probably doesn't matter that much, because you're actually producing antibodies and an immune response to maybe several hundred of the protein structures on the virus. So less than a 1% change in the proteome, the whole protein makeup of the virus, probably has very little response, because you're making this very polyclonal response because of this old-fashioned whole dead virus technique. So interesting. When I say old-fashioned there, I'm being in no way pejorative. No way at all. If things are working, then, if it ain't bust, don't fix it. But no publications, so we are somewhat unsure. Although from the countries that are using it, it's looking likely to be an efficacious vaccine. Let's just hope we get the data on it pretty soon. Similar situation to the Russian vaccine, to be quite honest. I mean, we ummed and ahed about Sputnik 5, but now the peer-reviewed data is there and it's efficacious. It's a good vaccine. I would have it if it was reviewed by my national authorities. Let's hope the Chinese one catches up and the peer-reviewed data is provided. Right, now, other things going on. Israel, South Africa variant, 44 cases, quite a few links being chased up. And they've come across 3 reinfections with the South Africa variant. Now, this is a concern. We looked at this over the last couple of days, a severe reinfection in France with the South Africa variant. Is reinfection with the South Africa variant going to be more significant of a problem compared to reinfection with a similar type of virus? Well, we don't know yet. We don't know yet, because we know there is a degree of infection, well, less than 1%. But that was before there was like 1%, less than 1% of reinfections on the Northeast healthcare workers data that we looked at before the UK variant, the new UK variant arose. So there is a degree of reinfection anyway. So is South Africa variant causing more reinfections? We don't know yet. What we do know is Israel has documented 3 cases of reinfection with the South Africa variant. We don't know how poorly they are. So that is one to wait and see. Slightly concerned, to be quite honest, but wait and see. Government in Israel is planning to launch a green certificate, enabling vaccine recipients to enter public spaces, stadiums, concert halls, performance venues. So is this going to happen in other countries? I suspect it will. And that is something that governments around the world are going to have to wrestle with. Slight concern, Purim, 25th of February, ultra-Orthodox community. Could be some super spreader events before the vaccine fully kicks in. So it could be a problem there. Let's hope not, although ultra-Orthodox have been a cause of spread in the past, as we've noted. Now, new variant again, France. South Africa and Brazilian variants now 5% of cases in France. So that has got the potential to grow exponentially, mostly in the east of France. Now, what the French authorities are doing is they're actually sending more vaccines to the east of France to try and reduce the spread with localised vaccination. So the UK government is strictly targeting those most likely to die from the vaccine. Here, the French government is using the vaccine more strategically, almost to try and ring fence an area where the South African and Brazilian mutations seem to be becoming more prevalent. So different approach. What I would say is if the South African and Brazilian variants take off in France, there could be a massive acceleration of this second wave, as we've seen in the UK. Because don't forget, in the UK, this line here was caused by the UK variant. That's why it went up from down there. I mean, if you look at there, that's the States there, and that's us there. We were way lower, and all of a sudden the UK absolutely spike up because of the new variant. That's what new variants can do. That's why we're still concerned. Now, World Health Organization, the COVAX program to supply vaccines around the world, especially to lower income countries. They've approved the Pfizer vaccine already. They've now approved 2 more. The Oxford Astrazeneca vaccine made in India and the Oxford Astrazeneca vaccine made in South Korea. Isn't it marvellous that the Oxford Astrazeneca vaccine is being made all around the world? Lots of different areas, and we looked yesterday at Australia, where it's being made in Melbourne, I think it was. So that's good. They're approved. The World Health Organization wanted to approve these separately, and they've approved both. They've approved it for all adults of all ages. All ages. That's good to know. 150 million doses of AstraZeneca vaccine should be made available to the COVAX programme for distribution to lower income countries in the first quarter. So that's, well, heck, we're well into that now, aren't we? So January, February, March. So we're expecting 150 million doses to go out in the next month, basically, the next 6 weeks. Let's hope that's true. 2 billion doses this year, not enough for the whole world, but a step in the right direction, going to 92 lower income countries. And this doctor from the World Health Organization Strategic Advisory Group of experts on immunisation says this: there is no reason not to recommend its use, even in countries that have circulation of the variant. Pleased to see that. South African authorities, please take note, because you're not distributing the Oxford vaccine. And the reason this doctor from the World Health Organization says that is there's good data to show that people don't get sick and hospitalized at anything like as high a rate, even with the new variants, as long as they've had the Oxford vaccine. So I agree completely on this occasion with the World Health Organization. This particular decision by the World Health Organization is a good one. Right, say no more. Tim Spector, COVID Symptom Tracker app. Now, they've got 450,000 people reporting who've had the first vaccine. Pretty well an even split between the Pfizer and the Astrazeneca. Now, side effects wise, the Pfizer under 15% report systemic symptoms, so quite a few do. Both vaccines more systemic side effects if people have had the infection in the past. So if someone's had the infection in the past, whether they know they've had it or not, then they're going to get more systemic side effects because they've got more of an immunological reaction. Unpleasant, but indicates that the immune system is kicking in and working big time. So unpleasant, but if you are going through that, then my understanding is that it's because your immune system is making you immune to this virus. It's in that sense, it is a good thing. More reactions in younger people who generate a higher immune response and in females who generate a higher immune response. Interesting. So again, the level of the adverse reaction or the side effect does seem to indicate how good the immune response is. And it is my view that if you are having a reaction following the vaccine, especially if you're generating a fever for that time when you're generating an immune response, in my view, it is better not to reduce that fever, because I believe the fever, if you have a fever, will be enhancing the immune reaction your body is generating. Haven't got any data for that, but that's my understanding. So if you can hack the fever for 24 hours while you generate the immune response, in my view, that will give a better immune response than if you treat the fever. We know that the immune system works best at pyrexial, warm body temperatures. People who've had the infection may not want to be having the vaccine within a few months of the infection. That's interesting. So if someone knows they've had the infection within the last few months, Professor Spector is saying they may not want to have the vaccine immediately in this round. So that makes sense. Now, the Astrazeneca vaccine itself, Oxford AstraZeneca vaccine, seems to cause less pain in the arm, but more systemic side effects. So does that mean it's generating a better immune response? We simply don't know yet. Twice as many people report systemic side effects that last for 1 or 2 days. Unpleasant, very unpleasant. Might need a day off work, to be quite honest. But it's a price I'm certainly personally prepared to pay. If someone says you're going to feel a bit rough for a couple of days, but hey, you're going to have fairly high levels of immunity after that, I would do it. Mild allergic reactions, the Pfizer less so than the AstraZeneca. Rashes, some swelling around the eyes, but not too bad. Tim Spector says the levels of reactions that they're seeing are fairly reassuring. And these are mostly people who are known to have allergic reactions anyway. People who have more severe reactions can be vaccinated under medical supervision. Very important if you have allergies to declare that before you're vaccinated, of course. Every single time I give out a drug at work, every single time, you always check for allergies. Absolutely every time, allergies and birthdays. So name, date of birth, are you allergic to anything? Every single time before you give a medicine, any medicine. What's your name? What's your date of birth? Make sure it's the right patient. Any allergies. Right dose of the right drug to the right patient at the right time via the right route, having made sure they are not allergic to that medicine. So anyway, Tim Spector said it's fairly reassuring. That's the point there. Level of protection. Now, we don't have the data so far for the Oxford AstraZeneca vaccine because, of course, the Pfizer started off sooner. Level of protection, Pfizer only so far. No protection at all for the first 13 days. Right. Important point, let's emphasise it. After the Pfizer vaccine, you have no protection at all for the first 13 days. None. 21 days to 30 days, full protection will develop. Quite a long time, 3 to 4 weeks before full protection develops. 68% protection against new infections, and that is after 1 dose. And people that do get infections, the ones that can still get infected, they are less ill, less severe disease if infected. And I don't think any of I don't know if any have been hospitalised, but certainly massively less sick if they do get infected. But for 1 dose, 68% reduction in new infections is excellent. Right, sorry, a bit long today, but I'll just finish off with Australia. Got an email from a doctor in Australia, a research scientist. I haven't got permission to use a second name yet. In fact, you can't see her. There we go. This is Susan in Australia. Now, she did clarify a few things for me. So she said when they talked about case by case. So yesterday, I'm afraid we were having a bit of a go at the Australian authorities, who didn't seem to be coming flat out and saying this vaccine is good for people over the age of 65. It turns out they actually weren't saying that. So I've been a bit harsh on the Australian authorization authorities by the sounds of it. So when they say case by case, they're basically saying that the doctors there can use individual clinical discretion, which of course they can. They're saying no efficacy issue in older people, so it works fine with older people. It's just possibly it might not be appropriate to give some people the vaccine. That's all they're saying. And the other thing, I've also criticised Australia about the delay in vaccinations. Well, it turns out that the delay and watching other people, e.g. the UK and the United States, be vaccinated, has reassured the Australian public. And we don't want to see that. We want to see Susan again. There we are. It turns out 91% of Australian citizens are currently going to accept the vaccine, which is good. So thank you for that, Susan. Appreciate that. And I would talk about your research, but I didn't really understand it. Something to do with designing huge molecules, I think. All sounded pretty impressive anyway. So good, thank you for that. What else did I want to say? There's always something else to say, but no, I was going to show you today, but I've gone on a bit today. But one of the things we're doing on this series, really, on these videos, is as well as talking about larger numbers, we like to get the individual experience. So I've got a follow-up video from Nick. So if you watched Nick the other day, a lot of people gave Nick very good feedback. We'll plan on giving more of Nick's experience tomorrow, but we've gone on quite long enough for today. So thank you for watching, of course.